Hi, everyone, and thanks for joining. We will get started in just a few minutes. All right. Hi, folks, and good morning, good afternoon, good evening, depending on where you're coming from. Welcome to today's webinar on advancing primary healthcare in Nigeria. My name is Stephanie Mork, and I'm the Communications Manager for the USAID Integrated Health Program, and I'll quickly be going through a few housekeeping items before we get started. Please use the chat to introduce yourself, to comment on the presentation, or note any technical issues. Please use the Q&A function to ask questions during the presentation. At the end of the webinar, there will be a dedicated time for question and answer. Please note that this webinar is being recorded, and the recording will be sent to your email after the webinar. I just want to quickly go through the agenda before we get started. So we'll have a couple introductions, and then the presentations today will include health outcomes and impact, a culmination of multisectoral, multifaceted approaches, from federal policy to community health practice, implementation processes and outcomes, tracking progress through quality data from health facilities through to national health information platforms, and improving coverage and quality of an integrated minimum service package at primary healthcare facilities. We'll also have summary remarks from USAID Nigeria and a question and answer session at the very end. So before we begin, I'd like to introduce our moderator for today's webinar, Kim Stover. Kim is the project director for the USAID Integrated Health Program implemented by Palladium. She holds a master's in international development and has been working in quality of care and quality improvement for more than 23 years, including more than 17 years on USAID's global flagship quality improvement projects. Kim has been working on IHP since 2018 and became project director in 2023. Previously, Kim served a quality improvement technical advisor on several USAID-funded projects across a range of health areas and served as the deputy chief of party on projects in Russia and Uganda. Over to you, Kim.
Good morning, good afternoon, and good evening to all of you. Thank you, Stephanie, for the introduction. I want to welcome everyone to today's webinar, and whether you're joining us today for the first time, or if you've been following along with IHP's webinar series, or you've been following us for the last 6 years, we are so happy to have you here today as we talk about our achievements and results. I want to say a special thank you to all of you who are current and former IHP staff, and to our partners, Jhpiego, Wyher, Avenir, Viamo, Pharmaxis, and Sidani. We could not have achieved these results without all of the contributions from the many, many staff, over 300 over the years. So thank you so much. Generally on the webinars, we stay off camera just for bandwidth, but I wanted to get on and at least say a quick hello. Before we dive in, it is my pleasure to introduce our first speaker for today's webinar, Dr. Marta Levitt. Dr. Levitt has spent more than 6 years in Nigeria in her current role as Chief of Party for the USAID Integrated Health Program Nigeria, that focuses on reducing morbidity and mortality of women and children under 5 years of age. Dr. Levitt has a PhD in medical anthropology and a master's of public health in international health and a population studies certificate. And she has over 40 years of experience working and residing in and traveling throughout Africa and Asia, designing, implementing, and leading global health projects. Marta is the founder of the White Ribbon Alliance for Safe Motherhood in India, and she was one of the original designers of the US government's Saving Mothers Giving Lives initiative, implemented in Zambia, Uganda, and Nigeria, that reduced maternal mortality by 44% in less than 5 years. We thank you so much, Marta, for all you've done over the years. Let me hand over to you.
Thank you, Kim. And greetings from Abuja, Nigeria, to all of people who are there, from all over the world and from all over Nigeria. So I'm just going to give you a quick overview, and then my colleagues will go into more detail. So the next slide, please. So the goal of IHP, as it was designed, is to contribute to state-level reductions in child and maternal mortality and morbidity, and increase capacity of health systems, both public and private, to sustainably support quality primary health care services. Next. So this is a 5 to 7 year project, so we're in our 7th year. And then our reach has been 4 states and the federal capital territory. So you can see here, we also have, we're calling from the Abuja Central Office, and we provide technical assistance to the federal level and support the states. And we also provide oversight to all task orders. Our coverage is 1,137 primary health care centers, 1 per ward, although in Bauchi it was more than 1 per ward, 90 general hospitals, 162 private facilities, and over 1,000 proprietary medical vendors and community pharmacists. Our overall key beneficiaries, 4.8 million women of reproductive age and children under 5 in the catchment areas in which IHP works. And our catchment areas of these PHCs represent about 52% of the total population of the 4 states and FCT. Next. So just to show you, we are a consortium. Kim has already recognized our partners, but we also work with other implementing partners funded by USAID and the US government, as you can see below. Next. So it's a very complex project, and we cover all 6 health systems building blocks, although some projects have taken on the HRH part and the medical technology, but that doesn't let us off the hook. We still are working at the PHC level with all 6 building blocks. Then we do maternal, newborn, child health, adolescent health, reproductive health and family planning, which includes GBV, nutrition, and malaria. And you can see the cross-cutting areas as well. Next. So I know you can't read this, but this just helps you to see how complex this project is. Gertrude, who is one of our managers, knows very well, and it's been very interesting to be able to bring all of these complex pieces together to provide client-centered services and ensure the best outcomes and quality of care, as well as increased coverage. Thank you. Next. So over time, of course, we've evolved, and we put our whole point of IHP is to put ourselves out of business. So as you can see, we started in FY19, and then that's with Bauchi, Kebbi, and Sokoto. So the northern states started in FY19, and we did PHC profiling. We also helped the State Health Insurance Agency, which didn't even exist, start and commence, and the Basic Health Care Provision Fund, which is the social protection scheme of the government of Nigeria, to start initiating, enrolling, operationalizing. This moved into a more foundational year in FY20, and as we all know, this is where COVID hit, but I have to say that we never stopped because the primary health care continued throughout the pandemic to bring services to the people. And I think that was they are the unsung heroes of the COVID pandemic, I have to say that. So we work a lot from federal level all the way down. You'll hear more about that from Dr. Gebbie, about policy to all the way implementation to the grassroots. As we had the COVID-19 response, we had to ensure that there were health workers at the facilities before we started capacity building, and we started to help the government to enroll the BHCPF vulnerable populations. And then we also began our low-dose, high-frequency on-site training at all PHCs. By FY21, we had reached full coverage, and we had also completed most of our training, although training and mentoring was a constant throughout the entire project till the very end. And then in FY22 to 23, we really focused on quality improvement and making sure that whatever services are being provided are following national standards of practice. And we also help the government to do more kind of innovative outreach, such as Open Maternity Day at the facility, and then to do their OIRIS Plus, not only RI outreach, but have a whole package of services, while we also worked on looking at the resources available, and we did some PHC makeovers. And finally, in the last year, we've very much focused on evidence-based practices and key intervention packages and tools that we were able to disseminate and hand over to the government so they can institutionalize and use it nationwide for scale-up. And we did end-line analysis, comparing baseline and end-line, and we are just finalizing our final report, which you can get on the deck later on. And then now our closeout webinar. Next. Okay, so these are just some of our results. As you can see, we had able to get to 706,118 lives that are protected in the financial risk protection scheme, starting from basically zero. And we worked on 64 federal policies that were domesticated all the way down to implementation, and trained over 27,000 individual health workers, managers, etc. Next. Okay, so here are some of the coverage outcomes comparing FY19 and 23. So for OPD, outpatient department, there was a 24% increase in people using OPD. Antenatal care in general went up 52%. Institutional deliveries at a IHP-supported facility, 37%. Vitamin A went up 194%. We did help the government to link with Vitamin Angels, so they had this constant supply. And then worked on malaria, both diagnosis and case management, and the increase in treatment went up 32%. And then measles too, which is now considered fully immunized, 70-fold increase over the years. Next. So I'm always interested in impact, those of you who know me, working on Saving Mothers, Giving Life. So just to show, one of our big achievements was a couple of years of protection increased by 126% over the years. And that was from the development of skills of the health workers who were community health extension workers and had never inserted an IUD or an implant before. So that really helped, and also advocating for more supplies. We were able to avert 1.2 million unintended pregnancies, 31,000 child deaths, and over 6,000 maternal deaths. Our maternal mortality, institutional maternal mortality ratio within the facilities where we work declined by 53.5%. So in line with Saving Mothers, Giving Life. I think, we know what needs to be done, and when we do it, we can see the results. Perinatal mortality also declined by 34%. Next. And I'm going to hand it back to Kim. Kim, over to you.
Thank you, Marta, so much for sharing the presentation with some of our key achievements and the impact of USAID IHP over the past 6 years of implementation. These achievements really represent the massive efforts and collaboration between the Nigerian government counterparts and IHP staff. We're very proud of what we've achieved. Next, I'd like to introduce our next speaker, Dr. Gebi Usman, who is the Deputy Chief of Party for the USAID Integrated Health Program Nigeria. Dr. Gebi is a physician and development expert with 30 years of experience in clinical and program leadership in the international development sector of Nigeria. Gebi previously served as Chief of Party on a complex PEPFAR-funded project where he provided country and program leadership, managed program and operational budgets, and facilitated relationships with the government of Nigeria and the United States government. He is trained in clinical medicine and holds a certificate in epidemiology from the University of Maryland and a certificate in leadership and governance from the Harvard Chan School of Public Health. Gebi, please take it away.
Thank you very much, Kim. I'm going to walk you through some of the challenges and experiences that we have had in trying to bring a vision into reality that kind of gave us the impact that Marta shared with you. Next slide, please. Remember that Nigeria basically has a complex health system that is multi-tiered from the federal government to the state government to the local government, ultimately to the facilities. Please, can we move the slide? Now, it's important for us to know that in order for us to be able to walk through this, it has involved a complex orchestra along these three levels, from the federal, state, and the local government. And IHP, particularly at the federal level, the so-called Abuja office, is actually the lead of that master orchestra. And the best way to tell about how we worked these policies and brought them to practice is through a short video that I want to tell our story from the various stakeholders so that they will tell their story themselves. So,
towards the implementation of primary health care.
Stephanie, we've lost sound.
Oh, I think it's coming through my computer, that's why. Not sure. No? Okay, I'll leave it to you guys.
Can folks hear?
No.
All over the country. So for you to effectively implement towards the implementation of primary health care under one roof in the states and the local government. IHP has supported different aspects, especially as it has to do with service delivery, service provision. Implementation is at the sub-national level. When I say sub-national, I mean the states and the local government areas all over the country. So for you to effectively implement primary health care, the first step starts with the establishment of the State Primary Health Care Board.
IHP, together with other partners, played a significant role in crystallizing the primary healthcare under one roof policy into the 9 implementation pillars. And we work to see, based on data that's available, to see what are the issues at the baseline at the various states. We identified together with other stakeholders led by NPHCDA to make sure that a framework was put that state governments have to be supported to make sure that those laws are kind of crafted and discussed with various stakeholders to make sure they give the necessary authority to, one, the formation of a semi-autonomous state primary healthcare board, which will be like the overarching governing structure at state that would kind of guide and support implementation of all service delivery actions at the state level and down to the local government.
The HP have helped us to be able to put our staff together, train them on their roles in PHCs, all cadres. Currently, all the staff of the PHC are under the agency, no longer in the local governments as before. Promotion, conversion of the staff that had not been converted to the scale of health worker, that's COHES, is ongoing, custody of IHP, you said. That's what we call integration in primary care under one roof. IHP did a lot in terms of training our staff, supervision of our activities in the PHC.
You also contributed in the tax shifting policy. What tax shifting policy has done was that there are key things they identify, and people were trained. IHP contributed immensely, they mentioned it, to this tax shifting policy. And tax shifting policy saves lives, reduces maternal mortality. So IHP invariably contributed to reduction of maternal mortality through tax shifting policy, which to me is great.
First of all, a big thanks to IHP for helping us to improve in our health management. They have brought to us knowledge on how to manage maternal mortality and morbidity rates. They also help us to know how to render family planning services.
Beyond the review of an implementation of NHMIS, DHIS2, IHP also supported systems at the federal, the state, local government, and facility levels to ensure data use, data analysis, and data use. And this involved working with technical working groups to strengthen the system to ensure that data was being used appropriately for planning.
During this partnership, a great impact was made in the area of health financing. IHP supported the state was strengthening the state contributory health insurance scheme. Through this partnership, the agency responsible for running the contributory health insurance scheme was supported to develop the guidelines and also standard operating procedures, which greatly improve the capacity of the agency to carry out its mandate.
You said IHP also facilitated the signing of Memorandum of Understanding between SOKEMA and the Nigerian Labour Congress, organized labor, including TUC and other affiliates, to see to the implementation of the formal sector program of SOKEMA. You said IHP also facilitated the mobilization of the informal sector, which we know is the virgin sector in the health insurance program. They facilitated the State Oversight Committee meeting, which is done quarterly to review the implementation of the Basic Healthcare Provision Fund, which we know is a program from the federal government to see to the enrollment and provision of services for the vulnerable part of the population.
An zo ƙauyen mu bakin kasuwa dafa, an ansa sunayen mu a mana rajista, kuma gashi ciki ya samu, na zo general asibiti ba an san kuɗi nawa ba, an min tiyata kuma an bani jini kyauta. Ina gode ma IHP kuma ina gode ma 'yan asibiti, Allah ya ɗaukaka, Allah musu ɗaukaka, ya girmama su. Na gode.
Thank you very much for the very brief overlay of the many hundreds of meetings and interactions we've had with people, and to make sure that this is coordinated to bring policy to action with results. Thank you. Kim?
Thank you, Gebi, for sharing those insights on moving from policy to implementation and for introducing the video. We truly feel proud of the fact that so many policies are now working on a day-to-day basis in these facilities based on the work. I'd like to introduce our next speaker, Dr. Olajumoke Azogo, who is a monitoring, evaluation, and learning expert. She has a PhD in information science and over 16 years working in public health to strengthen data and information systems. She has worked across projects funded by USAID, Bill and Melinda Gates Foundation, the Global Fund, Packard, and MacArthur Foundations for reproductive, maternal, newborn, child health, nutrition, malaria, and HIV/AIDS. Currently, Dr. Jumoke is the MEL Director for the USAID Integrated Health Program, Nigeria, providing strategic guidance, technical leadership, and capacity strengthening for MEL activities in support of the government of Nigeria and program implementation, leading baseline endline assessments, data analysis, and visualizations that have been able to demonstrate IHP's results. Please join me in welcoming Jumoke.
Thank you, Kim. Greetings, everyone, and good morning, good afternoon, and good evening, wherever you're joining us from. I am going to briefly speak to USAID IHP's strategy and approach to supporting the government of Nigeria health information system and ensuring the best quality data. Next slide, please. IHP's overarching strategy was to support the government of Nigeria within the provisions of the HIS policy to strengthen and support the government of Nigeria health information system, ensuring that no parallel systems were set up nor implemented. IHP worked at all levels of governance, federal, state, local government, and facility within the purview of the national HIS policy. IHP's work at the federal level included support to establish structures, the Health Data Governance Council, HDGC, the Health Data Consultative Committee, HDCC, and the MNETWG in its functions. IHP also provided the necessary technical support that saw the finalization of the NHMIS version 2019 tools, SOP and instructional manual, facilitated at master TOT workshops, and the associated upgrade of the DHIS2 national instance. Having identified gaps in the availability of and use of GBV and referral data, IHP worked with the government to develop and institute GBV referral addendum tools, also ensuring the creation of a staging server into which the expanded GBV and referral data are being reported. Other support resulted in the revision of data quality and assessment tool and methodology to a data quality and assessment and improvement tool and methodology. IHP is also providing support to the ongoing development of the NHMIS version 2024 tools. At the state level, IHP worked with established structures, again, the HDGC, the HDCC, and the MNETWG in its functions. Support to data systems and data quality across the state, local governments, and facilities ensured the institutionalization of, the implementation of, and use of the NHMIS version 2019 tools across all our supported states on the FCT and supported facilities, the use of the DQA and I tool, GBV and referral addendums, and the updated DHIS2. It is worthy to note that over 10,000 healthcare workers were trained over time on the use of the NHMIS version 2019 tools. IHP's support for data quality also included routine mentoring and supportive supervision with the state and local government 2 facilities, monthly integrated data validation meetings that encouraged peer-to-peer support, directly observed data entry to strengthen data entry into DHIS2, and the provision of desktop phones that enabled direct facility reporting. Next slide, please. IHP's efforts yielded results. Excuse me. This slide demonstrates the impact of IHP's technical support and assistance on data quality, accuracy scores, and timeliness of reporting. We can see accuracy scores consistently over the quarters, and timeliness of reporting also improved from being sporadic to being consistently over the acceptable 90% threshold. Next slide, please. Data analytics and visualizations were used by data control rooms at the state levels to review data for validity and data use for learning and programmatic decision making. This slide gives us examples of the kind of visualizations and analytics that IHP supported the government in creating and using. Manual performance charts were used at the facilities with very basic tools of cardboard and markers. Next slide, please. My final slide, this demonstrates results from the use of the GBV and referral addendums and the staging server that was set up. And this resulted in the increased availability of rich disaggregated data for decision-making in a user-friendly format. The addendum tools for GBV and referral are to be integrated into the NHMIS version 2024 tools, and it's expected that this will be cascaded to all states of the Federation beyond the IHP-supported states. Thank you for listening. I would hand it back over to Kim.
Thank you so much, Jumoke, for sharing more about IHP's work with the government stakeholders to improve the quality and functionality of the government's own data systems. Without this data, we wouldn't know what our achievements were. So this was a very critical aspect of the project. Thank you. Our next speaker is Dr. Ibrahim Kabo, who is the Chief Consultant Obstetrician Gynecologist with almost 20 years of experience in healthcare delivery, including 16 years consulting and working on projects funded by international donors, such as Bill and Melinda Gates Foundation, USAID, DFID, and UNFPA in different capacities. Dr. Kabo is currently serving as the Senior Technical and Knowledge Management Director for the USAID-funded Integrated Health Program under Task Order 2, the Abuja Central Office, and previously served as the Bauchi State Technical Director for 5 years. Dr. Kabo, over to you.
Thank you so much, Kim. Please confirm that you can hear me.
Yes.
Okay, thank you so much. And good morning, good afternoon, everyone. Next slide, please. So as we have heard Martha stated, that the overall goal of IHP is to contribute to the state level reductions in maternal and child mortality and morbidity. In Nigeria, a country with high burden of maternal and child death and disability, equally targeting state with least favorable health indices and weak health systems. So this required ambitious but carefully developed plans, implementation of evidence-based intervention at scale, and also the use of innovative approaches to increase coverage and improve quality for achieving desired results. So as we can see on the screen, IHP implemented a range of innovative approaches aimed at improving service delivery, strengthening systems, as well as improving governance. They were implemented by the state where IHP operated with the support of IHP in close collaboration with all relevant stakeholders. These include policy and guidelines domestication and implementation as stated earlier, development of harmonized and costed annual operational plans, competency-based clinical capacity building, facility management training, commodity availability, mortality audits, data quality validation and use, as well as health insurance scheme. Next slide, please. So those approaches that are used to kind of increase deliberately coverage of integrated services were seen that a large number of health facilities were supported to deliver quality integrated services as stated earlier. 1,389 health facilities, including primary health centers, secondary or referral hospitals, as well as private facilities, were supported with various interventions. But I think what is very important to note is that the secondary facilities that served as referral centers were hugely supported and strengthened to be able to receive and manage referrals, provide comprehensive emergency obstetric and newborn care, manage severe complications such as severe malaria, pneumonia, severe acute malnutrition, as well as provide mentorship to lower level facilities. For the capacity building, as we have heard in the video, the IHP supported the 5 states to operationalize the tax shifting tax sharing policy using the on-site low dose high frequency clinical capacity training approach to train a critical mass of frontline healthcare workers, 80% of whom were community health workers. And then with the aim to improve functionality, client privacy, and make health facilities ready for drug revolving fund, IHP equally conducted limited renovations to 211 facilities. IHP supported implementation of optimized integrated routine immunization services, ORIS Plus and open maternity days in 413 facilities, aimed at reducing barrier of distance for clients, increasing access, as well as strengthening referrals. One very important area that IHP supported that we are proud of is in regards to the support to the patent and proprietary medicine vendors, PPNs, and community pharmacies that are the primary source of medicine for common illnesses, especially in rural and hard-to-reach locations. And equally, they serve as source of advice about common illnesses, representing an essential opportunity for improving primary health care in such locations. So the engagement provided IHP and supported state with unique opportunity to enhance their capacity on timely identification and management of uncomplicated common childhood illnesses, as well as referrals, including counseling on family planning and provision of some services, as well as referrals. Another area is on universal health coverage, or the health insurance scheme that Martha made mention. Next slide, please. Yeah, so for quality improvement, IHP supported the state to ensure the capacity for quality improvement was available through development and domestication of statewide quality improvement plans that guided the quality of care goals and strategy for implementation, and also as well as resource allocation. So IHP transferred technical knowledge of quality improvement, strengthened performance management system for quality improvement, and another thing is embedded mentoring and coaching elements to ensure proper handholding, particularly in the development and testing of quality improvement projects at the facilities, and harnessing lessons learned for the entire process. Next slide, please. Next slide. Good. So Here, what we are seeing is that we assess the proportion of facilities offering the full package of reproductive matter and newborn child health, malaria, nutrition. What is, if you can see by the right, where we say the all states, the number of health facilities providing the full package of integrated services across the 5 states increased from 56 in 2018 to 91 in 2021. And we can see also the improvement is not the same across the state. So most significant improvements were seen in Sokoto, Ebonyi, and FCT, with increase of 56, 38, and 41% respectively. Next slide, please. Hello, next slide. So, thank you. Yes. So, baseline headline surveys at 929 PSCs were carried out to determine the extent to which these facilities across all the supported states and the FCT change in functionality to meet the minimum service package. So, to meet the national minimum service package, for this particular survey, 8 categories of services broken down into 29 parameters on functionality over the life of the project were used to assess changes between the baseline and the end line. And what I wanted to add is that 75% of these facilities are from the rural areas. So health facilities with the capacities to provide the minimum service package increased significantly from 13% at baseline to 48% at end line, while that is those that with a composite score between 51 and 58. And then the most significant improvement also occurred in the category of those that I was composite score ranging from 41 to 50, that increased from 35 to 45%. Next slide, please. So this graph shows performance of skilled birth attendance and pathograph use in the 5 supported states from 2018 to 2024. And as you can see, overall, we see gradual improvement and sustained gains in both indicators over the period of IHP engagement. Next slide, please. So, so for the newborn care, all IHP supported state equally recorded improvements in the use of 4% chlorhexidine gel for cord care and postnatal care within 48 hours, among other newborn indicators. What I just wanted to add here is that the tools and process for collecting data for chlorhexidine gel was only available after the introduction of the version 2019 NHMIS. Next slide, please. Okay, so I don't know whether, so thank you. For improvement in child health, this chart shows performance of 2 of those child health indicators we worked to improve. The red bars are pre-intervention, while the blue bars represent intervention period. What we are seeing is that we also see improvement over time with these indicators. Next slide, please. So the next slide is for improvement in malaria services. We have seen also improvements in adherence to malaria testing and treatment protocols across IHP supported states. So we have seen increased proportion of persons presented with fever and tested with MRT increasing from 88 in 2019 to 95 in 2023, while the persons with confirmed uncomplicated malaria treated with ACT increased from 92 to 97%. But what is also very important is the significant reduction we have seen in proportion of persons clinically diagnosed with malaria and treated with ACT. Another area that lastly that I would like to mention is to do with increase in provision of family planning services. So we have seen significant improvement in provision of quality family planning services, particularly the long-acting reversible contraceptives. I mean, all IHP supported state, IHP supported state. So we attributed this largely to operationalization of the national and domesticated tax shifting tax sharing policy that allowed a critical mass of community health workers to be trained to competency to provide family planning services, including LAC, to prevent unwanted pregnancy and avert maternal and child death. Thank you so much. Over to you, Kim, and sorry for my internet. Thank you, and over.
Thank you, Dr. Cabo, so much for your insights into how IHP worked to move the needle to improve access to quality health services in the supported states. One of the critical factors for success, as Dr. Cabo talked about, was the integrated nature of IHP's support across health system strengthening and service delivery technical areas. Another critical factor was the focus on implementing the government of Nigeria's priorities and policies and building up the existing systems to promote sustainability, not creating parallel systems. Next, I have the pleasure of introducing our final speaker, Dr. Gertrude Odezugu, who is the Program Development Specialist and Senior Reproductive Health Manager at USAID Nigeria. Since 2013, she has led many of USAID's technical assistance initiatives for health in Nigeria, managing a wide array of USAID-funded reproductive, maternal, newborn, child, and adolescent health programs. Gertrude focuses on equitable access to quality health services, especially at the primary healthcare level. She oversees the reproductive health family planning portfolio at the mission and serves as the USAID point of contact within the Family Planning 2030 partnership in Nigeria. And she is actively involved in advocating for family planning as a game changer for universal health coverage goals. Dr. Gertrude has served as the manager for several IHP task orders over the past 6 years and currently oversees our task order to the Abuja Central Office. So without further delay, let's welcome Dr. Gertrude for her remarks and reflections.
Yeah, thank you, Kim. Good day, everyone. Just checking that you can hear me. Can you hear me?
Yes, we can. Thank you.
Okay. So thank you, IHP team, for this lessons learned and dissemination webinar. We're all aware that primary health care can deliver about 90% of the essential services a person will need throughout their life. Primary healthcare also provides a critical platform for the delivery of nearly all services that are supported throughout USAID's global health programs. And primary healthcare is a cornerstone to achieving universal health coverage and SDG 3, good health and well-being, and pandemic preparedness. The presentations already covered practically everything. We heard about how IHP works with government and at federal and state levels to respond to COVID-19 in all supported states and PHCs, how we covered all 6 building blocks of HSS and the entire MNC continuum of care, the shared numbers of persons reached, 4.8 million women of reproductive age and children under the age of 5, supporting over 700,000 people with financial risk protection, through health insurance scheme. And, supporting state governments, local governments in having the data necessary for them to make decisions. We already saw that it's possible to reduce maternal mortality rates in states by over 50% and even reduce under 5 mortality by as much as a third. We also saw that IHP's implementation in Nigeria is really confirming USAID's commitment to PHC. Just to reiterate that Primary Impact is USAID's efforts to accelerate progress in health and survival globally through primary health care. So from USAID's standpoint, was big lessons learned, a huge project, just like Mata already mentioned, the numbers of people we worked with beyond the clients to the health managers at various level, from national, states, local government, even communities. In fact, I'm sure it's because of want of time we didn't quite even delve into many other areas that IHP covered, including electrification, community outreach, and the rest. So learning from our biggest PHC flagship in Nigeria so far, which is the IHP, USAID is committed to reducing inequities in life expectancy now and in the future. So thank you all for this opportunity to even work with Palladium and its partners in achieving all of this beautiful work in Nigeria. Thank you.
Thank you so much, Dr. Gertrude, and we also are very appreciative for all the support and guidance you've provided to us over the last 6 years. As a reminder to everyone, if you have any questions or comments, you can either raise your hand or please put them under the Q&A in the chat. I will start with the one question that we have under the chat, which is, actually, Jill, it looks like you've also raised your hand, so you can go ahead and ask your question. Let's see. Can we take her off mute?
Yeah, Jill, I just allowed your mic, so you should be able to unmute yourself.
Okay, I can go ahead and at least start with the question that she put into the Q&A. When will the 2024 DHIS data on GBV move from the staging server to be made publicly available? So that question would go to Jamoke.
Okay. Right, thank you for the question. The GBV and referral data is actually available through facilitated access onto the staging server, just like you would have service delivery data across other thematic areas for reproductive, maternal, newborn, child health, and so on through facilitated access. This is also available. Working with the Federal Ministry of Health, if one needs access, writing to the Federal Ministry of Health to ask for a username and password. The access, read-only access, can then be provided for the partner to be able to view the data. As I mentioned, the review for the NHMIS version 2024 is ongoing, and when that is completed, the GBV and referral addendum will become part of the suite of tools and then would be also integrated into the holistic national instance of the HIS2 and would also be available through that facilitated access. I hope that answered your question.
Jill, if you would like to ask additional questions or comments, please feel free to come off mute. Okay. So we have another question in the Q&A on the facility composite score on their functionality. Was this done using Perimeter's existing in the government HMIS? If not, it would be helpful to understand which parameters were used.
Want to answer?
Sorry, I didn't hear.
Sorry.
Sorry, I didn't hear. So please, can you repeat?
Sure. This is also in the Q&A. On the facility composite score on their functionality, was this done using parameters existing in the government HMIS? If not, it would be helpful to understand what parameters were used. So looking for what were some of the parameters in the facility score.
Okay.
Okay, thank you very much for an excellent question. Actually, the calculation of the composite scores for functionality were used with the parameters on the HMIS, particularly with the guidelines provided by the National Primary Healthcare Agency, specifying the expectations in terms of what are the elements that would provide what they call the MSD that would allow for a fully functional service delivery at a primary healthcare level. So it's actually the HMIS. We can actually go into share a link so that we can continue on this discussion on the methodology so that further clarity can be given to this. Over.
Thank you. The next, Jill has some great questions here in the chat, in the Q&A. Her next question was, how did you involve the women being served for them to express their needs? Possibly Dr. Cabo can speak to this. And if we have any of our former Jesse advisors, they can say a few words after that.
Hello, can you hear me?
Yes.
So how women involved, those that were being served, they express their need. So the frontline healthcare workers were trained to competency to be able to provide respectful care, as well as kind of provide patient-centered care approach. So in so doing, the counseling process that was balanced with the women kind of being involved, and also kind of allowing them to involve their partners and also to come with their partners, particularly where we also kind of conducted some platform sessions like the Open Maternity Days, whereby, not only women and men, those that are coming to the facilities are coming together to see how things are being done. And in so doing also, the community engagement, communities are involved to be able through the World Development Committees and village development committees to be able also to see the needs of the women and also kind of express their needs and see what are the gaps that exist and how the community and the facility, as well as the relevant stakeholders, can be able to address those additional needs if there is vacuum or gaps in those needs. So it is just like a continuum, from the community to the facility, and in so doing, the collaboration between the relevant stakeholders to see that, the needs are met, and those that are not there, the stakeholders are able to work together to provide or to address those needs. Thank you, and over.
Thank you. And the final question we have in the Q&A section at the moment is, what are the plans for pre-service training, particularly on GBV? I'm not sure if Dr. Gebbie, if you're able to field that question, or Marta.
Hold on, Marta, I love you muted.
Yeah, thank you. Thank you very much for the very good question. Well, it's like in terms of responsiveness for pre-service activities, the activities that IHP supported actually has been broken down. We are not responsible for pre-service activities. I think maybe I will not be in a position to say what the vision is for USAID. I don't know if Gertrude can maybe give maybe some idea in terms of what the vision is but it was not one of the things that IHP was in the menu of supported services. Over. Yeah, we've also put the question that was earlier asked on the composite score. We've shared some of the breakdown in terms of the things in the HMIS and how we're able to kind of weight this and identify the scores, the composite score for each of the facilities that we worked in. Thank you.
Thank you. Dr. Gertrude, would you like to speak to any plans for pre-service training, particularly for GBV? IHP itself did not work in the pre-service area. Yeah, please.
Yeah, no, IHP did not work in the pre-service area. We have the health workforce management that is working on pre-service training, and they actually have modules on gender, which I suppose should include GBV. However, beyond the health workforce management project, which is a separate activity, any other plans for pre-service training is not something that we don't know yet. You know, we don't know yet. Beyond what HWM is doing, we are not sure yet until we figure out exactly where the coordinating minister for health and his team are headed, and decide on what role donors and partners should play regards PHC especially. Over.
Thank you so much, Gertrude. And our former Kebbi State Technical Director also made a note that we helped HWM with some of the curriculum points that they were developing and had some of the GBV training incorporated into our low-dose high-frequency training materials, I believe in the family planning reproductive health modules. Thanks, Dr. Yusuf, for that comment. At the moment, I'm looking, we still have a couple minutes here, and I wanted to ask the panelists if you have any thoughts on what some of the biggest contributing factors for achieving these results were. Maybe I'll start with Marta and Gebby.
Okay. Okay, I was going to start with Gebby. I think the contributing factors is, first of all, we were out in the field. So we had offices in zonal areas that were able to visit primary health care centers on a regular basis. So we had a very deep and rich knowledge of their challenges as well as capabilities. And by understanding the root issues, we're able to address them with the government and the health workers. So, like, for example, there is a myth that women in the North don't want to use family planning for religious reasons. But what we found is that when we started to do the training on site at primary health care centers, women just lined up. And we ended up with a waiting list of women who wanted to get a modern contraceptive, in particular interested in implants, injectables, and IUDs. So this was a big surprise for us because we had assumed that there were these barriers. And then the next thing we had to do is make sure that not only were the health workers skilled, but that they had sufficient supplies because they were getting stocked out very, very quickly as people, it was just unknown how large the demand is. So I think working on skills as well as sufficient commodities were very, very critical. Gabby, did you want to add something?
Well, thank you. I think the only addition is that involvement of direct involvement of communities in terms of planning, as well as for them to come and see the new things, not new, the available services and what has changed from the routine thing that they are used to really contribute. And that Open Maternity Day really contributed as a kind of what I call, I don't know, it's like come see it yourself. And then it's like a word of mouth, spread the good things and then facilitated access. Over.
Anyone else want to add to that? Jamoke?
I just want to emphasize Martha's point about being on ground and have the hands-on interventions. I think along with that was the fact that we worked very intimately with the government at all levels, and they were carried along. Martha mentioned about working ourselves out of business or with the sustainability view in mind. I think that made a lot of difference also. Over.
Over back to you, Kim.
Thank you.
Can I add? This is Gertrude.
Yes, please.
Yeah, so I think from where I'm sitting, because I did not actually implement, but just to say that understanding that, it's not just about providing services, but, quality services. So the functionality of the primary health center, first of all, the building itself, the human resources, the commodities, the bed spaces, electricity, water, and then functionality also goes beyond all that to the health managers and their capacity to be able to have oversight, supervise, and all. So I guess what I'm trying to say is that it's understanding that it's beyond the actual just providing services, but all the other intricacies. I mean, maybe HSS, I guess that's summarizing it, will be the health system strengthening. It's very key, and that not having that, not taking care of the other HSS-based health financing, understanding that out-of-pocket expenditure can be a huge barrier to access, and and that you have to address that whether by yourself or in conjunction with somebody else, is very important. And I think that's one of the key reasons, the key contributors to success. Over.
Thank you so much, Gertrude.
Kim, do you mind if I add to what Gertrude?
Absolutely.
Thank you so much for reminding me about power and electricity. One of the things we noticed immediately is that most facilities had either no access to any kind of electricity or was very intermittent, and it really affected the quality and access to the services, especially deliveries at night. We ended up developing a coalition of the Power Africa as well as the health sector folks coming together to figure out how to get electricity and sustainable electricity to primary health care. I would like to thank our colleagues at We Care Solar, who partnered with us and donated over 300 We Care Solar suitcases to light up every birth inside the labor rooms. It makes such a difference. And we were able to see, like, almost instantly over a few months, the number of deliveries in a health facility that went up. So access is more than just, walking to a facility. It's also whether they can use the facility once they get there. And as Gertrude said, it's costs. Costs are a big barrier. So the more we're able to enroll people in a health insurance scheme, the more they'll be able to use services without fear of out-of-pocket expenditures. Thank you.
Thank you so much, Gertrude and Marta, for those really poignant comments. depending on how you count it, IHP covered more than 30 distinct technical areas, as you can hear. And so it's impossible for us in one presentation to really go into depth across all of these areas: health system strengthening, community level services, service delivery. And it was really the combination therein that was so critical. We have one more question in the Q&A. For the team in Abuja, any comment on the performance in non-program states?
Non-program states.
Non-program state. So,
well, I think if I may comment on that, I think in some of the discussions we've had with key stakeholders, particularly at NPHCDA, many of the lessons that have been pulled in from IHP, where there has been integration and using national systems, it has kind of provided some degree of background into some of the things that worked in kind of shaping the swap agenda. Because if you look at the swap agenda, basically it's about integration, one plan, one monitoring mechanism, and the results of IHP kind of contributed into strengthening that vision of government. And we really think that it's like it was something that provided that information that is going to help government of Nigeria as well as the partners to move forward. Over.
I think that also brings us to the whole point of sustainability. I noticed someone asked their fear of how sustainable. So the first thing is that everything that we did was through a government system, facilities, so that we're not creating parallel systems, outreach. So trying to improve what already existed. So that's number one. So already it belongs to them. We're just strengthening what they were doing and helping them put their really beautiful policies into action. And I have to say that you should read, if you don't have a chance, read the PHC Under One Roof. I think it's a brilliant document. And then the whole PHC revitalization. So some of the policies are fantastic, the task shifting, task sharing policies. So making them come alive, making them a reality in Nigeria. And these lessons hopefully will be able to be used by non-supported states, and they can take it from there. So we're hoping that what we have been able to do, we have key intervention packages that have been handed over to the government. We have tools, data visualization. We have so many things that we have available, and making sure that the government has availability to scale these up and use them nationwide. And one more thing I think that Gertrude pointed to was that we helped work with the NPHCDA to do a financial and facility management toolkit, because these officers in charge are health workers, and most of them are community health extension workers, never trained in management. And we realized a lot of money was starting to flow in from various sources, and they really didn't have these skills or the tools to be able to manage these different pools and sources of money that they can then use to improve the services, the infrastructure, and bring in more staff to make them better functioning. So that was done through with NPHCDA, and now it's being scaled up across the country. So I think main thing is to make sure that what we do is not a parallel thing. And I think this is something that, we always had to remind ourselves that this government, whatever government's doing, let's try to make sure that we're strengthening what they're doing. Sometimes we have to demonstrate something done in a slightly different way, and then the government sees it and say, oh yeah, I really like that. Let's do it that way. It's not that it's a different program or a different scheme, but it's just showing them a how to do the, let's say, the initiatives that they have. Thank you.
Thank you so much, and we've reached time. I just want to ask Dr. Gertrude if she has any closing comment or would like to say anything in relation to those discussion points, and then we will close.
No, Kim, I think we've all said it all. Like, it's been an interesting conversation. If I think majorly the fact that there are lots of questions, even from USAID standpoint, the questions are thought-provoking, especially Jill's questions on GBV. You know, it's already got me thinking about what we could do next. You know, but really, I think, well, USAID still believes in integration, in multisectoral approach to addressing primary health care issues, at least in Nigeria, where I am in right now. And I'm sure it's not totally different. You know, the picture can be totally different in other countries or similar countries, you know. So, yeah, thank you all for being here. And thank you, IHP, for the great work. Just like your audience, we're all looking forward to having access to the materials on the deck, the materials from this webinar and all, because I can see that there's great interest. Many partners and donors, you know, would really love to learn how you reached the majority of people that you reached, and you know how you were able to make so much progress, especially in this climate. So thank you, great work. Thank you all for participating.
Thank you so much for those closing remarks, Dr. Gertrude. Again, we want to thank all of our presenters. And I also want to just point out, again, we've had a lot of former and current staff on the webinar, and just want to make a huge note of appreciation to everyone who's contributed, our partners, the extensive staff, and the support we've had from USAID over the last 6 years. We're so grateful to everyone and so pleased that we've been able to reach these achievements. Thank you, everyone, and good day.